Welcome back to the Deep Dive. Today, we're getting straight to the point. No fluff.
We're going strictly clinical.
We are tackling a huge topic for anyone prepping for plastic surgery boards. The clinical management and reconstruction of lip carcinoma.
Oh, this is a big one. For any oral board, FRCS or otherwise, this is where you can really show what you know.
Or get completely stuck.
Exactly. It tests oncology, your anatomy, your reconstructive skills all at once.
So our mission today is to frame this just like Aviva. We're going to give you the high-yield facts you need. Anatomy, pathology, and, of course, the reconstructive ladder.
We're aiming this right at the resident in the hot seat. You need to be able to see the problem and just talk through the solution.
Okay, before we dive in, just a couple of quick things. We know you use this for revision. If it's helping you, please take a second to rate the show. It really does help.
And if there's a topic you're struggling with, leave a comment. Let us know what you want us to cover next.
And one last thing. For those of you who want to go deeper, remember that our Journal Club and Clinical Cases deep dives are only on the premium subscription.
All right, that's the housekeeping. Let's get into it.
Okay, exam mode on. Let's start with the absolute foundation. Anatomy.
Always.
First question. It sounds simple, but it's a classic trip-up. How do you surgically distinguish the lip from the oral cavity?
It's all about the mucosa. You have to look at the vermilion border.
Right.
You have the dry vermilion, which is the part you see, and then the wet mucosa on the inside. The lip officially becomes the oral cavity right at that junction.
The transition from wet to dry.
That's it.
All right, let's go deeper. Vascular supply.
Mm-hmm.
You have to know this or your flap is dead. What's the arterial anatomy we need to know for reconstruction?
You're talking about the labial arteries. Superior and inferior. They form a sort of continuous loop.
Okay, a loop. But here's the money question, the one they're really asking. Where is it? What layer?
Right. And it's not subcutaneous. That's the trap.
So it's not in the fat.
No, it's deep. It runs between the orbicularis oris muscle and the mucosa itself. Actually, it's often just under the mucosa on the inside.
Wow. So if you're dissecting and you're too superficial, you could just miss it.
You could miss it. Or worse, if you're too deep on the mucosal side, you cut your pedicle. You have to picture that artery hugging the lining, not the skin.
Got it. Okay, now let's talk about where the cancer spreads. Lymphatics. It's not just one spot, is it?
Not at all. It depends completely on where the tumor is sitting.
So what's the general rule?
The main drainage for the lip, broadly, is to the submandibular nodes. But you have to be more specific than that in an exam.
Okay, so let's say I have a tumor right in the middle, midline lower lip.
That's your danger zone. That drains to the submental nodes first.
And the key point there is?
It can cross the midline. You absolutely have to mention that.
So you can't just check the one side?
Never. You have to think about bilateral drainage. The lymphatics, Dick, you say it right there.
And what about the corners of the mouth? The commissure?
That's another special case. It can go to the submandibular nodes, sure, but it can also drain to the paraparotid nodes.
So you need to examine up towards the ear.
You do. Your exam has to include the parotid gland, not just under the jaw.
Okay, anatomy's locked. Let's switch to pathology.
Oh.
Rapid fire. Most common tumor on the lip.
Squamous cell carcinoma, SCC.
Main cause.
Sun. Long-term UV exposure. It's almost always that.
Now, a key distinction. Is an SCC on the lip the same as an SCC inside the mouth?
No, and that's a critical point for prognosis. A lip SCC acts more like a skin cancer, a cutaneous SCC.
So better behaved.
It's generally less aggressive than a true intraoral cancer. The prognosis is better as long as you get it early.
Does location matter? Lower lip versus upper lip?
It absolutely should change your thinking. The vast majority, something like 95% of lip SCCs, are on the lower lip.
Just because of sun exposure?
Yeah, it's a shelf. It just catches the sun. The upper lip is relatively shaded.
So if you see a tumor on the upper lip, what should you be thinking?
Your first thought should probably shift to basal cell carcinoma, a BCC. It's a classic board question. Lower lip, think SCC. Upper lip, think BCC.
Okay, prognosis. Let's talk numbers. What are the factors that really affect a patient's 5-year survival?
Two things: size and depth of invasion.
Be specific.
A tumor bigger than 2 centimeters, or any tumor that's invading the underlying muscle. Those are your big red flags.
And what does that do to the survival rate?
It's a cliff.
Yeah.
For a small T1 or T2, you're looking at 75 to 80% 5-year survival.
Pretty good.
Right. But if you have one of those bad factors, a T3 or T4, it drops to 40 or 50%.
Wow. Okay, that's a huge drop. Which it brings us to excision. You're in the OR, you're marking the patient. How wide do you go?
The standard UK guideline, and it's pretty widely accepted, is a margin of at least 6 millimeters.
Is that a hard and fast rule?
It's the baseline. If you've got a really big tumor or it's poorly differentiated, you need to take more, but 6 millimeters is a number to quote.
Okay. Now, the examiner pushes back. Why are you operating at all? Why not just use radiotherapy?
It's a fair question. For early stage disease, the cure rates are actually pretty similar.
So why surgery?
Because radiotherapy has its own problems on the lip. You get fibrosis, dryness, chronic irritation, and if it comes back, reconstruction on a radiated bed is tough.
But is there ever a time you'd actually prefer radiotherapy?
Yes, one specific situation.
Which is?
A small tumor right at the commissure, the corner of the mouth.
And why there?
Because surgically restoring a functional continent commissure is incredibly difficult. Radiotherapy can cure it without destroying that function.
So you're preserving the sphincter.
You're preserving the sphincter. You might choose the beam to avoid the knife in that one spot.
Last pre-op question. You feel the tumor and it seems stuck to the jaw.
Stop. That's a hard stop. If
I
there's
feel-
any suggestion of fixation to bone, you need pre-op imaging, mandatory.
CT scan.
CT, MRI, something to tell you if the mandible is involved before you go in.
Okay, tumor's out. Now for the hard part. Reconstruction. We have to start with the master, right?
Sir Harold Gillies. His 1920 principle still holds up.
And that is?
Restoration is designed from within outwards.
Break that down for me. What does it mean practically?
It's a hierarchy. Number one, you restored the lining, the mucosa. If you don't have a good seal on the inside, it fails.
Okay, lining first. Then
Then the support, which is the muscle. And last is the skin covering. You have to build it in that order.
and what's the best building material?
Lip tissue. The principle is replace like with like. Nothing is as good at being a lip as other lip tissue.
Right. Let's talk function. Upper versus lower lip is one more important.
Oh, much more. Function is critical in the lower lip.
Why is that?
The lower lip is the dam that holds the water in. It prevents drooling. It gives you oral continence.
And the upper lip?
A static upper lip is actually fine as long as the lower lip works and can press up against it. The lower lip has to be dynamic.
So the goal is to rebuild the muscle.
The goal is to reconstitute the orbicularis oris. That's your functional reconstruction.
Perfect. Let's get to the main event, the reconstructive ladder. We're going to go defect by defect.
Let's do it.
Scenario A. The cancer is superficial, just mucosa. Muscle is fine.
That's your vermillionectomy, or a lip shave.
So what are you doing?
You excise the affected mucosa, and then you advance the mucosa from inside the mouth forward to cover the defect.
Okay, simple mucosal advancement. Next, scenario B. A small, full-thickness defect. Let's say less than a third of the lip.
This is your classic wedge excision and direct closure.
Is there a hard limit on how much you can close directly?
The general rule of thumb is up to about 25% of the upper lip and maybe 30% of the lower lip.
But that depends on the patient.
Totally depends on tissue laxity. An older patient with loose skin, you can get away with more.
Okay, you're doing a wedge on the lower lip. How do you design it to get the best scar?
You use a W-plasty at the base of the wedge
Why a W instead of a V?
to avoid a straight line scar crossing the mental crease. That can contract and pull the lip down. The W-plasty breaks up that line and prevents contracture.
Smart. Okay, let's go bigger. Medium defects. Between 1/3 and 2/3 of the lip, direct closure is out. What now?
Now you're borrowing tissue. Your main options are the cross-lip flaps, like the Abbey or the Abbey Eslander.
Explain the Abbey flap.
You're taking a full-thickness wedge from the healthy lip, say the upper lip, and you swing it down into the defect in the lower lip, leaving it attached on a small pedicle.
So their mouth is temporarily sewn, partly shut.
For about 2 to 3 weeks, yes.
Right.
Then you come back for a second stage to divide the pedicle.
Okay, what's another option?
The carapansic flap. This is a big one for exams.
Right. What's the key advantage of the carapansic? Why choose it?
It's all about function. It's the only one that preserves the nerve supply.
You don't cut the nerves.
Exactly. You carefully dissect and preserve the neurovascular bundles as you rotate the remaining lip tissue in, so the flap has feeling and it moves.
That sounds amazing. What's the downside?
Microstomia. A smaller mouth opening. You're closing the hole by making the whole circle smaller.
Got it. And for the upper lip, is there a specific flap?
Yes, the periolar crescentic flap. You excise a crescent of skin next to the nostril, which lets you advance the cheek in to fill the defect. Hides the scar beautifully.
Okay, up the ladder again. Large defects, more than 2/3. Let's start with the upper lip.
Now, you're probably combining techniques. maybe an Abbey from the lower lip plus a paler cheek advancement, or you might use a nasolabial flap.
And for a large defect of the lower lip, name the workhorse flaps.
The two big ones are the Gillies fan flap and the Webster-Bernard flap.
How does the fan flap work?
It's a big rotational flap. It pivots on the commissure and fans tissue from the cheek and upper lip down into the lower lip defect.
And the Webster Bernard.
That's a cheek advancement flap. You're basically pulling the cheeks forward to make a new lower lip, usually excising some Burroughs triangles in the smile lines to let it move.
But with both of those, what are you sacrificing compared to the Karapansic?
The nerve supply. These are almost always denervated flaps.
So you get coverage, but no function.
You get a static dam. It stops drooling, but it's not a dynamic moving lip. It's a salvage procedure.
And finally, the top of the ladder, a total lip defect. The whole thing is gone.
You're out of local options. At that point, you need free tissue transfer.
A free flap.
A free flap, a radial forearm, or an ALT flap. You're just bringing in tissue from somewhere else to close a massive hole.
Okay, let's run that ladder back real quick. Mucosa only.
Vermilionectomy.
Small defect.
Wedge and direct closure with the W-plasty.
Medium defect.
Abbey or the innervated Karapansic.
Large defect.
Gillies fan flap or a Webster-Bernard.
Total defect.
Free flap.
If you can recite that logic, you're in a great position.
Absolutely. It shows you have a plan.
So before we wrap up, let's talk aesthetics. The primary reconstruction is done. What's the one thing that almost always needs a touch-up later?
The commissure. The corner of the mouth.
It's just hard to get right the first time.
It's so hard. Even with a dedicated flap like an S-lander, they often need a secondary revision just to get that shape right.
Which brings up a good final thought.
Yeah.
We have all these flaps to fill the hole. But what are we really trying to recreate?
Exactly. You think about a natural commissure, it's not just a sharp corner.
It's subtle.
It's incredibly subtle. The way the vermilion thins out, the way all the facial muscles come together at the modiolus, it's complex geometry.
And you can't really make that out of a big square flap.
Not perfectly. And that's the biggest aesthetic challenge. We can give them a mouth that doesn't leak, but recreating that perfect, subtle corner often eludes the primary surgery.
And that's why you have to warn the patient from day one that a revision might be needed.
It's not a complication. It's part of the plan. It's about managing expectations.
A fantastic point to end on. Okay, that wraps up our revision deep dive.
Hope it was helpful. Good luck with the exam prep.
Remember, if you found this useful, please rate the show. And if you want our journal club and clinical case deep dives, you know where to find them on the premium subscription.
See you next time.
Thanks for listening.